Suicide risk screening and using a tool to do that is a way to help healthcare professionals start the very awkward conversation of how you ask someone if they're thinking of killing themselves. And so that's what we're going to go over. How do we standardize it for healthcare workers so that it's fast? We know that these questions have been tested through research, so it's not going to over detect or under detect. And it's 4 questions. So I'm going to talk about screening. And, you know, our society, we're used to screening, right? Everybody gets a blood pressure when they go for any medical visit. That top right is the hospital at NIH, the clinical center. We used to screen for COVID. People get screened in airports. And some kids even get screened when they go on a roller coaster, right? So we're used to screening. But I want to really drive home this point that there is a difference between screening and assessment. They are 2 different things that people often mix up and interchange these words. They're not the same thing. Suicide risk screening or screening is just a very rapid way to identify someone who needs further evaluation. We don't go from a screening to a diagnosis. We don't go from a screening to a disposition. We go to the next step, which is an evaluation. The assessment is a more comprehensive evaluation. It confirms the risk. It guides next step. Screening and assessment, both very important in the clinical pathway that we're going to talk about today. Today, we're focusing on the screening. How do you identify someone who needs further assessment? That's what screening is meant to do. So what are the valid questions that healthcare providers can use in a medical setting to screen medical patients and behavioral health patients for suicide risk? Now, I'm highlighting the word valid because when we first started this work, I would go to a hospital and I would hear, you know, the Joint Commission would say, okay, you need to, there was a national patient safety goal. There is a national patient safety goal that says you have to screen all behavioral health patients for suicide risk. So I would ask them, what is your suicide risk screening questions? And they would say things like, I've heard everything. So I've heard a hospital say, have you ever thought about suicide? So what's wrong with that question? Well, you can imagine if you ask a bunch of adults, especially adults that maybe have chronic medical illness, if they've ever thought about suicide, they may. Now, do they need help right that minute? Probably not. It might have been something they thought about a lot. It's too broad of a question. Had no time limit on it. I heard one emergency room ask, how will I know if you're angry? That was their suicide risk screening question. So when people make up their own questions, it over and under detects. So we wanted to, through research, create the questions that would be effective and efficient. And so we launched this study. I'm not going to go into the details of the study for time's sake, but it's the ASQ started in a pediatric emergency department in Boston, in Washington, D.C., in Columbus, Ohio. And, you know, we're pretty proud that most tools in the world go from the adult world to the kid world. The ASQ actually went from the pediatric world to the adult. It's also been tested in adults. So it's one tool for all ages. But the sensitivity and specificity or true positive and true negative rate, that limits your false positives, your false negatives. And so they're very strong. And so this is the ASK. It's meant to be very blunt, very direct. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If the patient says yes to any one of these 4 questions, they're given an acuity question. And that's the 5th question. Are you having thoughts of killing yourself right now? So as Dr. Enderhorn said, there's 3 outcomes from the ASK. You can screen negative, which most patients are going to do, or you can screen acute positive or non-acute positive. So what we know from big data sets is that, and you know, Dr. Enderhorn just gave you some of that data. What we know is that there's one study I'm thinking of now that looked at 90,000 patients that took an ASK. So maybe in this one study, 97% of them look like this, right? So most patients are going to look like this. It's going to be a negative. It's no, it was 20 seconds and you're done. Okay, so this is what makes screening feasible. If most of the patients, if I was telling you that 97 of the patients are going to screen positive, that'd be a different story, but somewhere in the 90% is going to screen negative. Now, you are going to be prepared for those positive screens, and that can be a yes to one or more. And then you ask the fifth question, right? If someone's negative, you don't ask the fifth question. If someone's positive, you say, are you having thoughts of killing yourself right now? So there's two ways to screen positive. If someone says no to this question, but yes to the above, they're considered a non-acute positive. I can tell you again from this data that 99.5% of positive screens are non-acute positive. Okay. However, it's important to be ready for that yes to Q5. That's the acute positive. That's the emergency. So again, as Dr. Endeforn said, the acuity in the native population is higher. And so we're ready more often for the acute positives, but it's still the majority of the positives are non-acute. So the ASQ has been tested through research in inpatient medical surgical units, in ERs, in outpatient primary care and specialty clinics, in adults, in youth. It's being tested with ongoing research in these places. In Black, of course, we're so excited about our partnership with IHS. It's been translated into over 23 different languages and validated in some of those languages. And it comes with a toolkit, which you see at the bottom of your screen. And Tessia, you can put that in the chat, please. Okay, so I want to go through sometime, so when the Joint Commission said, everyone should screen, the National Patient Safety Goal is to screen behavioral health patients, but there was a recommendation to screen all patients for suicide risk. A lot of people said, well, we're doing depression screening with the PHQ-9. Depression screening, suicide risk screening, probably very similar, right? And people think this, but we didn't think this. And the PHQ-9 is a really good depression screen, and depression is prevalent, so we should be screening for depression. But there's a 9th item of the PHQ that says, how often have you been bothered by the following symptoms during the past 2 weeks? Thoughts that you would be better off dead or of hurting yourself in some way. So that's considered the suicide risk question. There's 3 things wrong with this question. The first is it says, have you been bothered? So you have to be bothered. And sometimes when people settle on wanting to kill themselves, they're not bothered anymore by the thoughts. It also has an or in it. So you don't know which side of the question they're responding to. So it over and under detects. And then it says hurting. It doesn't say killing. And we all know that people think of hurting and killing themselves as 2 different things a lot of the time. So this question isn't so good for suicide risk. And so there's at least 13 studies now showing that the PHQ-9, while being a good depression screen, is not sufficient to identify people at risk for suicide. But we embedded this in our adult medical patient study. And so I'm just going to show you, we had about 727 medical surgical inpatients and 116 screened positive for suicide risk. And then 175 screened positive on the PHQ-9. And then 49 of them endorsed that 9th item. And what we found is, had you only screened for depression with the PHQ-9, you would have missed 1/3 of the people at risk for suicide. And had you only relied on that item 9, which a lot of places did, you would have missed 63% of people who were at risk for suicide. So the moral of this, or the finding from this study, the conclusion is, by all means, screen for depression because that's prevalent. But if you want to screen for suicide risk, you have to use a suicide risk specific screening tool. Now, some people screen like this, and for depression, this is a valid thing to do. They use the PHQ-2. If that's positive, then they use the PHQ-9. However, sometimes they only screen the patients that screen positive on the 2 and the 9 for suicide risk. There's no evidence showing this is valid way to screen for suicide risk. And why would you make a patient jump through all those hoops when it's 20 seconds more? So one of the things we did was we stuck the ASK on the bottom of the PHQ so that people would ask both. Okay, so using a suicide specific screening tool like the ASK, we're going to now talk about screening specifically for suicide risk. So what is the role of the screener? The screeners are going to, and the first thing is that leadership is going to decide in your specific venue who is going to screen. So one of the things that we have learned from consulting to hospitals around the country is that there's 100 different ways to make suicide risk screening work effective and efficiently in a medical setting. But each setting has to do it in a way that works for them. And through quality improvement process, you find what's the best way. So the first thing to do is you pick your screener, and the ASK was really developed for nurses, for medical technician, for medical assistants to start the screening when they do the other nursing assessment questions. So but anybody who's trained can screen for suicide risk. Screeners are going to screen every new and returning patients over the age of 8 years old. So in the emergency departments, it's going to be every visit. In an outpatient clinic, it's going to be every 90 days. And in an inpatient or residential treatment facility, it's going to be every admission. So again, different in each venue. And because each site is going to develop their own pathway, and we're going to help with that, there's going to be nuances that are different, but this is in general. Some of the things that apply to everybody are things like telling a visitor or a parent or a guardian to step outside while you're doing the screening. And it's important at this point, you don't want to turn to the parent or guardian or visitor. Like, let's say someone's there with their spouse. You don't want to say to the patient, do you want your husband to stay or leave? You don't want to say that. You want to, because that puts the patient in too much of a hard position. You just say to the visitor, I'm going to ask you to step outside for a minute, and I'll, come back and get you when it's time, but it's a minute. It's not a trip to the cafeteria, or it's just a minute. If then the patient protests and says, no, I want my husband to stay, then of course they can stay. But this is the way that we have seen it work most feasibly. You say to a parent, and I'm going to go over scripts and how to introduce this, but a parent, you say, I'm going to ask you to step out for a minute, and if I have any concerns about your child's safety, I will let you know, so it's not a mystery. And then you administer the ASK verbatim. And I can't emphasize how important it is to ask the questions exactly like they're written. And I say that because each question was tested through research, was statistically modeled to be on this screen. So there have been some times where I've done trainings and then I come back a few months later and some of the nurses have told me, well, we didn't like the questions, so we changed them. And I'll tell you, like, you can't change the questions. That's the one thing you can't do, because again, then you're over or under detecting, right? So you got to ask the questions exactly like they're written. You score the ask in real time, which just means if they say yes to any one of the questions, then they're positive, and you ask the 5th question, right? And then you report the screening findings to the medical team, the behavioral health team, before they go in the room. And that's really important so that everybody knows maybe this person's there for a well visit, maybe they're there for their annual physical and they screen positive. You want the medical team to know that at the outset, because this could turn into a very short conversation, or it could be a very long conversation, and they need to know that up front. Okay, so this is the clinical pathway that I've been talking about. These are the bare bones, right? It starts with a brief screen with the ASK, which we're training on today. One of the most important parts of the pathway is second tier, the brief suicide safety assessment. That's going to further triage the screen. Because remember, we talked about the difference between screening and assessment, and we need that middle assessment. And that helps you determine the third part, which, what does this patient need next? Is it a full mental health evaluation? Can they leave and then come back for that when that's available? Or do they need that right now? Or do they need to be sent to the emergency room? Or no further action is really required at this time? So these are the bare bones of a feasible, evidence-based clinical pathway that hospitals are using around the country, and it's working. I'll tell you that. It's not theoretical anymore. It is working. So again, we're gonna, in the IHS system, we're gonna screen kids 8 and over. And then sometimes people will say to me, well, what do we do for the kids that are under 8? What if they come in talking about suicide? And unfortunately, and very sadly, there are children under the age of 8 that think about suicide and even attempt suicide. It's rarer, but it happens. So if you see those warning signs in a child, or a parent is telling you, my child, every time I discipline them, they grab their throat or they threaten to run in front of traffic, then I would do an assessment. We don't have any suicide risk screening tools that are valid for the younger kids, but you can assess them and you can talk to them and find out what they're thinking about this. This is where you move. You don't need detection anymore. You need assessment. And then again, anyone who's trained to screen for suicide risk can screen. Okay. We're going to talk about where I said that the ASK needs to be administered verbatim. Every question, every one of those 4 questions read exactly. I'm not saying that for the script. The script should become your own, and you should do what is comfortable. But here is our suggestion. And a lot of people start with our suggestion and then they find their own words to talk about it. So our suggestion is your safety is our #1 priority. Sometimes people struggle with mental health concerns, and sometimes people even have thoughts of suicide. Therefore, we're asking all patients a few questions about suicide risk, and then you administer the ASK. And then how you get a visitor to leave is, again, we have a few questions we ask in private. I'm going to ask you to step out of the room and give the patient some time, a few minutes of privacy. We also sometimes pair that timing of the suicide risk screen in an outpatient setting with the abuse and neglect screen, because we're asking someone to leave the room and leave the patient in private. And then you can ask other questions like that you want to ask in private. Okay, so while the script can become your own words and what you're comfortable with, there are some things to be mindful of. There's do's and don'ts of introducing the screening. One thing I've observed a lot of people screening. You don't want to be apologetic. You don't want to say, I'm so sorry, I got to ask you a few questions about suicide. My hospital's doing this and this is new and we got to do this. You don't want to introduce it like that because you don't do anything else like that, right? It's going to stigmatize it further. It's already stigmatized. We don't ask people, would you like to be screened for suicide? Don't ask them that. Just screen. Just like you don't say to somebody, do you want me to take your blood pressure? Do you want me to take your temperature? This is like a vital sign. We just do it. Just like we don't ask the patient if they want the visitor or parent to leave the room, we just tell them very politely to leave the room. The important parts when you do make the script your own for introducing screening, it's important in your voice that you make it sound routine, like there's a lot of things that we ask that are very sensitive, right? It's not just suicide risk screening questions that are sensitive. You're asking people important questions about their body, about their health care, about their medical care, about their disease. These are all sensitive questions, right? So we want to put it on par with those. It's important in your script to say that you're screening all patients for suicide risk. And the reason that's important is because there are some patients that might feel like you're picking on them. Why do you think I'm crazy? Why are you asking me? You preempt that by saying, because of the stigma, you preempt it and you say, we care about everybody's safety. We're screening all patients over the age of 8, so you're getting screened too today. It's important to consider local cultural customs and beliefs of the patient, of the tribes you're working with, right? Like I had a nurse, I was in a medical setting a few months ago, and it was outside of this hospital, and I had a nurse screening me, and she was looking at her computer screen and she said, no self-harm, right? And that's how she screened me. And she didn't make eye contact. She asked the question in a negative, like, you're not thinking of suicide, are you? Right? That doesn't open up. That doesn't leave me a lot of room to talk about my suicidal thoughts. And she didn't make eye contact. However, we know that there's some cultures where making eye contact is also thought to be aggressive or too assertive. And so it's important that however the local culture, that you take the local culture beliefs into consideration. So if you're not asking any other questions with direct eye contact, because that's being sensitive to the culture, then you don't want to make direct eye contact during asking about suicide risk either. So you just want to put it on par with all the other questions that you're asking, and you want to be culturally sensitive. Okay, and I've said this several times now, is that you tell the patient, the visitor, to leave, but if the patient wants them to stay, they can stay. All right, so what happens when a patient screens positive, right, on a suicide risk screen? Well, here's what should not happen. And I can't tell you how important this piece is. We cannot treat every person who has a thought about suicide like they're an emergency, because otherwise they end up in a paper gown. Their phones are taken away. They're given a very costly one-to-one sitter. They're there for hours. And you might be the first person to ask this patient about suicide, and they just decided to open up. And now what do they feel? They feel punished, like they did something wrong, like they're in trouble. And so and also from those big data numbers that I gave you, we know that most people who are thinking about suicide are not an emergency. It's good that you identified them for needing help, but they don't need this. Some people do, and most people don't. So using this clinical pathway that I'm going to talk about over and over today, this is the guide to avoid these unnecessary interventions, because this feels punitive to the patient, and this is what overwhelms your system, right? So I've seen emergency departments where anyone who says anything about suicide gets put in this paper gown, and then all of a sudden they have an inordinate number of people in paper gowns with a sitter, and they can't handle it, and it shuts the screening program down. And this is not necessary, right? This is not compassionate. This is not patient-centered. So we believe our pathway is a way to avoid this. So the ask is binary, right? You're either negative or positive, and then when you're positive, you're either acute positive or non-acute positive. And so this is a way to avoid putting someone in a paper gown. Now, there are people who are a danger to themselves and at risk for suicide, at imminent risk for suicide. So let's talk about them first, because these are the acute positives. So acute positive is a yes to 1 through 4 and a yes to 5, right? So that 5th question determines acuity. This means patient is at imminent risk, and screener needs to activate high-risk precautions. All those things I just said that most of the time we don't need, for an acute positive, we need. So this patient can't be left alone. This patient needs a one-to-one sitter. Any harmful items from a room are removed. But knowing if it's possible, a lot of times in a medical setting, you can't remove all the harmful items. And you know, that's okay. This patient cannot leave, and this patient needs an emergency mental health evaluation. Now, all this should be done compassionately. Patients still should not be treated like they're some kind of criminal or did something wrong. It should all be spoken about in safety. I am worried about your safety. I want to keep you safe. We are really worried about you killing yourself. We are going to make this room as safe as possible. We're going to get someone who's trained to talk to people about suicide to come speak with you. It still should be done in a very compassionate way, because this is a sensitive matter. This person wants to die, and you want to save their life. So here are some, again, this is suggested script. You can make it your own. You praise the patient for talking about something that's so hard to talk about. I'm really glad you're telling me about your thoughts. I want to keep you safe. I'm going to ask, and then here's where your plan that you've all been trained on comes into play. I'm going to ask Miss Snyder to conduct a further mental health evaluation. She's going to come speak with you, and someone else is going to sit with you until she gets here. Okay. And what you say to a parent is, right, you don't want to say your child's suicidal, or you don't want to say to the patient you're suicidal. You want to talk about it in safety. After screening, we have some concerns about your child's safety. We're going to follow up with a safety evaluation. I'm going to ask Ms. Snyder to come speak with your child, and they're going to speak with you too, parent, about next steps. Okay, so those are the important parts of putting together what you say to people when they screen positive. So everybody's got to be prepared for that acute positive. More likely, it's going to be a non-acute positive when it's positive, right? Yes to 1 through 4, any of them, no to 5. This means you detected something really important, but it's not an emergency. But the patient needs further evaluation, right? Because it was just a 20-second screen. You want further assessment. Screener contacts the clinician who's going to do what we're going to call a brief suicide safety assessment, or a BSSA for short. Patient needs this further assessment, and this patient can be left alone, right? This is not the emergency. This is not the paper gown. This is not the sitter. This patient can be left alone. They're asked to stay until this evaluation is done. However, just like with other medical tests, if they decide that they're leaving, then you treat this as against medical advice. Just like if they had a skyrocketing blood pressure and you said, I want you to stay, I'm going to get cardiology to come see you, and they don't want to wait for the cardiologist, no one's going to tackle them in the hallway, right? But for some reason, when it comes to a mental health concern, people get activated. This is on par with other medical tests that are positive but not emergencies. Now, you can have your own plan to follow up with this patient. Like at our hospital, when these patients leave, someone from the medical team calls them and say, see, you didn't stay for the assessment. Can you come back for that another day? Can we, you try to reach out to them, but they are allowed to leave. So after a non-acute positive, what you say to the patient, I'm really glad you're telling me about your thoughts. It's important that you spoke up about this. I'm going to ask Ms. Snyder, who is trained to talk to people about suicide risk, to come speak with you. And then again, you talk about it in safety. I want to make sure you're safe. And then what you say to a parent is, after screening, we have some concerns about your child's safety that we'd like to further evaluate. It's really important that your child spoke up about this. It's a brave thing to do, right? I'm going to ask Ms. Snyder, who is going to come talk with you and your child about suicide risk and further do the assessment. Again, it's important to alert the medical team. If you're the screener, you want to tell if there's a nurse practitioner or a physician assistant or a physician that's going to come see the patient. You want to say before they go in the room, this patient screened non-acute positive for suicide risk. They screened acute positive. That's something you just tell everybody right away, right? And then documentation, so important. You document the suicidal statements. And we're asking you to do it objectively. Don't put your own opinion in there. Just say what the patient said verbatim. Patient answered yes to questions 1 and 2. And all your EHRs and IHS, thanks to Captain John Lester, your EHR will capture all this information. And in the free text, you try not to over or under report, right? Just state what happened. Patient screened positive on the ASQ. I asked the parent to come back into the room. I asked I told the physician who's going to see the patient in advance, document who was notified, document the plan, and any interventions you took if there were any. So the documentation on this is really important. Okay, additional considerations for the screening. What if the patient refuses to answer the questions? So most of the time patients will answer your questions, but sometimes they won't. If they're an adult, they're allowed to decline medical tests. Just like if you say, I'm going to weigh you today, and they say, no, I'm not jumping on that scale. They're allowed to decline medical tests, right? But you document that they declined to take the screener. If they're a young person, if they're a kid, then we consider them a non-acute positive. And that's because we have data showing that kids who refuse to answer the ASK have significant psychiatric histories and are at higher risk. We talked about asking questions about suicide. Can it make the patient suicidal? No, it's the opposite, right? What if patient doesn't seem like they're suicidal? Do I still need to screen them? And I can't tell you, you can't see suicide risk a lot of the time, most of the time. I can't tell you, even in people who are trained to, right? I work on a psychiatry consult service in this hospital. I'm always assessing someone for suicide risk. I can't tell you how many times I'm surprised when they say yes to the question. I think in my head, this person's not at risk for suicide, and then they tell me they are because I asked. So you got to ask every time when you're, on your pathway, when you're supposed to ask, you screen. What if patient starts talking to the screener about their suicidal thoughts in detail, right? Because I'm going to say, as a screener, I'm going to say, have you ever tried to kill yourself? And they might say yes. And I might say how, and they might start going into a lot of detail. And then they might just keep talking about it, right? So we're training you as the screener. It's okay to politely interrupt them. And you say, let me interrupt you for a minute. I am so glad you are talking about this. This is so important. I'm going to go get someone who's trained to talk to people about suicide risk to come speak with you. And they're going to help you and figure out next steps, right? That's how you stop them. Because we don't want to put we don't want, patients are going to talk about this and that's good, but we don't want to put that on the screener. What if parent or visitor refuses to leave the room? You should screen in front of them then. The downside is people are more honest when they're alone, but the upside is that you might be modeling how to talk to people about suicide risk in front of them. So it's okay. What if you're in a shared room and the patient doesn't have privacy? And this happens in our hospital a lot. There's a lot of things we do in those shared rooms that are pretty private, right? And we do them hopefully not in loud voices, but you should do it like you do everything else in a shared room, right? You don't want to be, talking about all kinds of medical issues and then you get the suicide whisper, right? Because that further stigmatizes it. So it's unfortunate when the patient doesn't have privacy, but you do it like you do with every other private piece of information that you're trying to extract from them, right? And then the last thing I want to talk about is contracting for safety. So in the old days, we used to say, okay, now you screen positive for suicide risk, promise me you're not going to kill yourself. This is not valid. We don't do this. We don't make the patient promise. Instead, the person who's going to come do the brief suicide safety assessment with them is also going to make a safety plan, right? They're not going to do contract. They're going to do a safety plan. What are you going to do if it's 2 o'clock in the morning and you're thinking about suicide? what are you gonna do? Let's come up with some coping mechanisms. That's a safety plan. That's not what the screeners are gonna do. I'm just telling you that we don't make patients promise and things like that. Because this has been being conducted in hospitals and medical settings throughout the country, in non-IHS settings as well. We have a lot of information. There have been teams of clinicians and researchers doing studies, and what we found, and we try to use this research to keep improving the process. So one thing that we found is the most common presentation of a positive screen is going to look like this. Okay, so that's a non-acute positive. That's what we're calling a sole yes to past behavior. So there's bad news and good news about this presentation of a screen. The bad news is there's a lot of people out there who have tried to kill themselves in the past. So that's very sad and tragic. The good news for the screener is that it may be very far in the past and not something that you have to manage in your setting that day. So it's always good to know about someone's history, but it might not be what I'm going to call the business of the day. So what we see through, and we see this everywhere, is that a third to a half of positive screens look like this. So you can, that's going to happen. And we don't want, and I think I said this in the beginning, but we don't want this to be like, we had a patient who was 80 and tried to kill themselves when they were 20, and they spent the next 60 years not trying to kill themselves. We don't want to use resources on someone who doesn't either need them or want them, right? So it's important that people who screen like this not be put through the pathway if they don't need it. So I'm going to show you the caveat to this. The other thing that's going to happen is once somebody screens positive like this, every single time they come in, they're going to be positive, right? Because once you have it in your past, you have it in your past. So we, and through the help of Captain Lester, have tweaked the EHR now that when you have this, you can say, and it's a non-acute positive, you can say to the patient, since last visit, have you tried to kill yourself? And if that's no, and everything else is no, then the patient can move out of the pathway and you just go on with whatever they came to the clinic for.